Dear Chairman, dear colleges, I would like to present you our study title as Myocardial Deformation, Tissue Characteristics and Systolic Recovery in Anterior Myocardial Infarction. This study aimed to assess the diagnostic power of two-dimensional strain parameters compared to CMR-defined area at risk and infarct in patients with anterior ST elevation myocardial infarction and their predictive power for long-term recovery. Patients diagnosed with first anterior ST segment elevation myocardial infarction and successfully reperfused were enrolled in the study. The patients were referred to echocardiographic strain imaging and CMR within first week after their index admission. A follow-up echocardiographic examination was performed at 6 months. Exclusion criteria were the patients with left bundle branch block, atrial fibrillation, and any other irregular rhythms, implanted cardiac devices, prior history of coronary artery bypass grafting, and any conditions for CMR imaging, claustrophobia, glomerular filtration rate below 30. Segmentation model was used. Peak systolic strain, akinesia or dyskinesia, early systolic lengthening, simple postsystolic shortening, 20% postsystolic shortening, diminished longitudinal peak strain was defined according to the literature. Total segments showing edema in T2 weighted mapping, infarct size was defined as the total segments showing late gadolinium enhancement. These are the analyses that use. The final study population was consisted 17 patients. Cardiographic measurements at baseline and at 6 months follow-up are summarized in Table 1. The frequency of the presence of individual myocardial deformation parameters are summarized in Table 2. The power of myocardial deformation parameters for predicting CMR-based ischemia parameters and long-term recovery is summarized in Table 3. Myocardial deformation analysis has evolved rapidly in the past decade. Namely, global longitudinal strain has become a standard parameter used in daily clinical practice and being preferred over left ventricular ejection fraction in many circumstances. However, a comprehensive strain analysis provides not only a global value for the whole left ventricular, but also time-varying deformation curves for each myocardial segment. For instance, postsystolic shortening has already been acknowledged as a sensitive marker of myocardial ischemia. Early systolic lengthening has been associated with coronary artery disease. Decreased longitudinal peak shortening has also been interpreted as sign of decreased myocardial performance in ischemic heart disease. Despite positive previous studies, our results indicated that these deformation parameters are not good surrogates for CMR-defined edema and infarct segments. Although postsystolic shortening with a strict definition has more than 20% additional segmental shortening after aortic valve closure exceeding the value at aortic valve closure has a slightly better discriminative value. Our study was underpowered to claim that this was a statistically significant one. Although this may reflect the limitations of strain imaging, it may also hint that CMR-based definitions do not directly reflect myocardial damage as perfectly as previously taught. Our study has several limitations. Firstly, our study size is quite small. Secondly, we use a Decomotus 17 segment approach for presence or absence of myocardial deformation and CMR parameters, a quantitative approach might be more definitive. Thirdly, there is no universal definition that is agreed upon for segmental improvement in strain values. In conclusion, myocardial deformation parameters have a low diagnostic accuracy for predicting ischemia tissue characterization in CMR, imaging, and long-term recovery. Further studies should be conducted.